Fabulous day, actually, in which I think for most of us that are doing clinical hepatology, today would be like a typical day in clinic where we see a lot of patients with NASH. We're troubled by all the HCC we're saying, and then we're dealing with our cirrhotic patients and their complications. And that was also capped off by 2 terrific state-of-the-art lectures on cholestatic liver disease and liver imaging. So let me just try to quickly sort of remind you of where we've been today. We started out with an absolutely fabulous talk on the pathophysiology of NAFLD and NASH, really focusing on that fat was necessary, but really the driver of the underlying injury involves many processes, and I think the emphasis in Massimo's talk was really looking at some interesting aspects related to autophagy, oxidative stress as sort of primary drivers. And in particular, what I took away from his lecture that I thought was very important is this first phase of adaptive response, when really the individual has fat in the liver and where the hepatocyte, the liver, is sort of dealing with that hepatic load, and then a steatotic load, and then literally moving on from that to get the various components of injury and ultimately fibrosis. So a beautiful really reminder for us about the stage-dependent mechanisms for NASH. The other aspect that I thought very fascinating in this talk was this potential concept of steatofibrosis, in which that may be a direct link with some forms of hepatocellular carcinoma, that there isn't necessarily always an inflammatory injury component, that steatosis and fibrosis can sort of be sort of a unique entity, and really I think understanding that component and its relationship to HCC I think was stressed beautifully in the talk. And then finally, we all know that PNPLA3 is linked with a higher rate of getting both NAFLD NASH, also linked with higher rates of NASH-associated cirrhosis, and I think understanding sort of what is it around PLAP and PLA3 that is responsible for this increased risk, and I think some very nice data, and it's as yet unpublished, but beautifully shared with us, was really talking about PLA3 SNPs and how they promote the activation of the the stellate cells that then lead to this dysregulated oxidative stress response. So sort of coming back to that original oxidative stress response. So that was a beautiful way to sort of set the stage for then Francesco, who went on to look at the natural history of NASH and NASH-associated HCC. And everybody in this room knows that this is an incredibly prevalent chronic liver disease, but not just in Europe, not just in the US, but globally, with about 1 out of every 4 individuals affected. It parallels the increasing prevalence of metabolic syndrome, which he showed us very nicely in the data. And also we're seeing more of this because of the aging of the population. And then what I think was very interesting is looking at sort of the projections for both NASH and also NASH-associated HCC. And what we've already seen in 10 years, the last 10 to 15 years, is there was already a 10-fold increase in NAFLD-associated HCC. And it's clear that all of us are going to be dealing with this as the predominant form of HCC in the very, very near future. So shown and reminded in this talk was that fibrosis and not NASH is really the predictor of survival, and that's really the impetus behind all of the clinical trials right now, which are very focused on fibrosis as the endpoint largely. And then shown on the right is this very interesting data showing this 10-fold increase in NAFLD-associated HCC. So really very, very dramatic and really just the start of this very impressive trend. Francesco also highlighted that there's up to 53.8% of HCCs that occur in the absence of cirrhosis. So this is a little bit scary, I think, for many of us, with the sense of how are we going to identify such individuals. And so he reviewed with us the risk factors for HCC and NAFLD, not surprising, obesity and diabetes, but also hypothyroidism, and very importantly, again, the PNPLA3 genotype, in which in the setting of HCC, we see that the G allele is associated with a doubling of HCC risk. So it's possible that in the future we'll be able to use genetics and other aspects to help inform how we're going to screen individuals, both who have cirrhosis, but also importantly those without cirrhosis. And then he finalized his talk really looking at some of the chemo prevention, particularly around the issue of HCC. And in this regard, I was very tickled sort of to see that he was focused on exercise and the very interesting animal data and now some human epidemiological data that show that exercise is an important modifier of HCC risk, with about a 25% reduction in those that are regular exercisers. So I think the message from his talk was exercise, exercise. He also talked about chemoprevention, and in particular the kind of provocative, interesting data related to metformin and statins. And statins was a pretty consistent message as we went through the HCC talks, as you'll see. And then Professor Casteros or Laurent focused on non-invasive markers, but I thought was beautiful his talk, because he actually took us to sort of the bigger problem of how are you going to manage to identify all these individuals that have NAFLD or NASH. How are we going to identify those in primary care that really need to come to hepatology? And in his really very masterful talk, he talked about the components of availability, cost, applicability, and context of use as being the important issues that are going to really drive how we put together algorithms of non-invasive tests. He also showed that the transient elastography, FIB4, and the NAFLD fibrosis score, these are cheap tests, perform very well in terms of being able to identify those individuals who are at higher risk and therefore potentially need to be referred. I'm going to show you his two algorithms on the next two slides, but I think it was really this nice emphasis on the fact that we, as hepatologists, have to now look to our primary care or diabetologists and help them to come up with algorithms to identify the patients that should be referred to us. And so shown here is his suggested algorithm for the primary care, and I think what's really interesting about this is it starts with a simple blood test, like a FIB4 that anyone, anywhere can do. And then you really dichotomize very quickly those patients into those low risk versus those that are intermediate high risk. And then that individual patient who's intermediate to high risk goes to the hepatologist to then undergo a further workup. He talked also about really an alternative, which is the diabetes clinic, where we know there's a lot of NAFLD. And here, in contrast to the PCP setting, here the FibroScan would be, or the transient elastography would be your first test, using the liver stiffness again here to triage your patients into two camps, one of low risk, one of intermediate high. And then again, that intermediate high group gets referred to the hepatologist. But these are all algorithms that I think all of us are going to be having to implement in our various health systems. So I think helpful as a starting point for us to think about this. There was a lot of interlacing of histology throughout the talks and the questions, and Dr. Bodessa gave a really wonderful talk on really liver histology, but more importantly, I think helping us to understand the NASH-CRN definitions of how they've classified NASH, where its deficiencies were, and where improvements can be made. It's clear that liver biopsy is and will remain the standard for diagnosis of NASH, at least for the near future. That this classical definition, the NASH-CRN, needs improvement, and that a new scoring system is particularly important because all of the clinical trials are being driven by histological endpoints. So we need an endpoint that's both valid, reproducible, and has the granularity to be able to detect differences. And so what he did was, and I love this slide, was he showed on the one side the NASH-CRN staging system, and then really on the right shows the things that can be improved upon in terms of thinking about a better way for us to be doing staging of our patients with NASH, and in particular to look at how specific therapies may be improving the components of both NAS and fibrosis. And then we went on to management, and Anna Carolina Cardoza gave a very nice talk on management, highlighting for us once again that this is a multi-system disease. While we are very focused on the liver, that we can't forget that the most common cause of death is actually cardiovascular disease, and that our patients also are at risk for renal disease, pancreatic disease as well. And so when you treat with the idea of what is an effective therapy, you want to be thinking about how it's going to impact those other diseases. Much of her talk was focused on the cornerstone of treatment, which is weight loss, because it's recognized that weight loss not only impacts liver, but also cardiovascular and the other comorbidities. Remembering that very modest weight loss can result in substantial improvements in histology, that a 7 to 10% weight loss, for example, results in improvement in NASH score parameters, and a greater than 10% weight loss results in improvement in fibrosis. She then reviewed with us the various elements of how weight loss plus other aspects of management we use every day in our clinic. I'm going to sort of, she touched on the diet, but this was followed up in the next talk in more detail. The role of exercise again, The potential use of medications that might suppress appetite as an additional way to lose weight. The use of bariatric surgery, but to do so very selectively, recognizing it's not perfect, and then some of the medications that have been looked at in early studies, vitamin E and pioglitazone. Dr. Sanyal gave us the update on the new developments in NASH, and I'm not even going to try to cover any of them, actually, because there are so many. I was very impressed at how quickly he got through about 15 drugs. But it's a very bright landscape in terms of many drugs, primarily in phase 2, but we do have 4 drugs that have made it into phase 3. All of them, as you know, largely are focused on a histological endpoint when it gets to phase 3, but a very exciting time. But one of the aspects that he focused on that I think bears more attention is the role of addiction. That this is really like alcohol, like many other forms of addiction. We have to think about obesity and sort of a food addiction in the same way, and start to think about potential mechanisms that might really be focused on that as the particular target as a way for us to treat the obesity and then the associated diseases such as fatty liver disease. The other aspect that I thought was quite novel is this idea of doing duodenal mucosal resurfacing. There's a lot of interest, at least in the United States, on the role of endoscopic therapy in terms of managing obesity. And this is, I think, very provocative in terms of another way that we can think about managing our fatty liver disease patients. He closed with this management paradigm that he sort of laid out for the next decade. Of course, it relies largely on staying focused on weight loss through lifestyle measures, but we have some drugs available to us that are that look encouraging in the context of managing NASH, such as statins, fibrates, the GPL-1 agonists. So those are likely to sort of find their way into managing patients, especially those that might have diabetes, for example. And then we're very focused on this sort of preventing end organ damage, and he emphasized in his talk that really the sort of sweet spot for much of the drug development is really for patients who have F3 disease, where we really have this potential to sort of pull them back from the precipice and reverse their fibrosis, that maybe it's a harder bar to be treating patients with already established fibrosis. And clearly, as we start to understand how these drugs work, using them in individuals with less fibrosis would be important. And then finally, of course, to emphasize that ultimately cardiovascular disease is still important, and thinking about how we're going to manage the entire patient and reduce the morbidity and mortality related to disease is important. Dr. Romero Gomez I loved his talk on the diet, because this is probably the single most important thing that a patient wants to get from you is how you want me to lose weight, what diet should I follow? And he gave a very beautiful overview of really the data that informs a recommendation. Clearly shows that dietary modification is an effective way to treat NAFLD. He focused on this nutritional geometry, and that's shown on the right, where it's really just thinking about sort of the whole process of how we, not only just a diet, but how we think about patterns and how we think about micro and macronutrients, looking at sort of energy balance. And he really proposed, and I think this is really the way forward, is that we'll have future algorithms that'll be much more of a specific diet for a specific profile, and that we'll be using artificial intelligence to help inform this personalized form of nutritional counseling. In the end, what he left us with is that the Mediterranean diet wins, that coffee is good, and that I think everybody should add olive oil to their diet. And clearly, these are the factors that have been shown in several studies to come out as being contributory to benefits in terms of patients with NAFLD. And this was just one way that he sort of, a beautiful review that really looked at all of the aspects related to the different diets and looked to see, does it help with weight loss? Did it result in improvement in insulin resistance? Did it lead to improvement in triglycerides? And only the Mediterranean diet was really able to achieve all of those metabolic as well as hepatic benefits. So front and center, that's the diet we should recommend. Now we're going to shift to pedestal carcinoma, and Dr. Neon gave a beautiful talk, I think, really highlighting, and this is my favorite figure, I think, to really highlight the various components that are involved, both a management of the liver disease itself and how do we prevent the liver disease from contributing to HCC, but also enumerating the tumor characteristics, as well as sort of understanding the biology and molecular aspects of the tumors to help inform us in terms of our optimal management. One of the things that he focused on was the sort of really rapidly evolving use of percutaneous therapies and how that really has become another form of curative therapy for many of our patients. And I think really sort of gave a state-of-the-art information about the newer techniques that are forthcoming. He also highlighted, and as did the next speaker, the important role of immune checkpoint inhibitors. This class of drugs single-handedly is really kind of, I think, really providing great hope for our patients with more advanced HCC. And in this particular instance, we are also interested in how these drugs may be useful in patients who have undergone curative therapy, but now are at potentially high risk for recurrence, and is there a role for them in that setting? Several important trials underway. And he left us with really a reminder of the importance of biobanking. When we look ahead to like how breast cancer is so nuanced in terms of its care these days, we too need to get there with HCC using our tumor genomics to help us in decision making. And so he made a very strong, I think, and compelling argument for us to continue to biobank tissue so that we'll be more informed about this as the years go by. I talked very briefly about the role of liver transplantation for HCC. It accounts for about 1/3 of the transplants in the US and Europe. We continue to work to go from Milan to beyond Milan, and in doing so have added not only size and number of tumors, but also AFP in response to local regional therapy as ways to improve our prognostic methods. And clearly we're making progress. Modest expansions of Milan criteria have resulted in actually excellent outcomes with liver transplantation. For those that recur, our outcomes are very poor. Fortunately, our recurrence rates are relatively low with good selection of patients, but you can see here that only resection really yields reasonable survival, and this really highlights, A, the importance of doing surveillance to detect cancer recurrence early post-transplant, but also the need for us to do more therapeutic trials in this particular population. And Professor Sangro gave a lovely review of immunotherapy for HCC. And in particular, he talked about the immune checkpoint inhibitor as this key therapy that's emerging for patients with HCC, that we are seeing now durable and clinically relevant responses with few side effects. So we should all, I think, really be very encouraged by that. There's some new combinations that are coming down the pike as being first-line therapy that also, again, are going to tap into the available checkpoint inhibitors that are in development. And really what I'll show you on his summary slide, I think, is really to highlight that on the left is really where we are now with current guidelines. And you can see that in general, when we have individuals who need systemic therapy, we've been focused on the tyrosine kinase inhibitors. But his view to the future is that that's going to change, and we're likely going to move to having checkpoint inhibitors or other combinations with the checkpoint inhibitors as our primary form of therapy. This could really revolutionize, I think, in some ways, the response that we're getting with systematic therapy. So certainly at the end of his lecture, I felt much more optimistic. Professor Burrows gave a wonderful talk on cholestatic liver diseases and cholangiocarcinoma, and I'm just going to I'll show you quickly this one. I thought this was a beautiful, he showed a case, took us through a very exhaustive evaluation of that case, and then in the end reminded us that it's history that often comes into play, and I would say particularly in these unusual cholestatic liver diseases. He also highlighted the new therapies that are forthcoming for our 2 chronic cholestatic liver diseases, PBC. We all currently have 2 approved therapies, but there is still room for improvement with benzofibrate likely to be approved or recommended in this coming year, but also room for more new therapies, and he highlighted those. The area where we have no approved therapies currently is PSC, and this is where I think all of us are looking for new therapeutics. And in reviewing the pathogenic model for PSC, he highlighted, I think beautifully, how these various therapies might tap into either blocking or reversing or interfering with the various stages of PSC. So looking to the future, we're hopeful that some of these new therapies will ultimately come forward as being our first approved therapy for PSC. And finally, we'll talk about cirrhosis. And Professor Godano gave an update on what's new in portal hypertension, reminding us that we are now very careful about looking at describing compensated versus decompensated cirrhosis and really this entity of clinically significant portal hypertension. and that the role of liver stiffness by transient elastography is now helping us to to really characterize who has clinically significant portal hypertension. Oops, sorry, I just went by. So in using the combination liver stiffness over 21 rules in clinically significant portal hypertension, so that's very, very informative and gives you a sense of your future. And we can use also elastography and platelet count to identify individuals who are likely to have varices or unlikely to have varices and therefore avoid EGDs. He gave us an update on several new trials that are looking at various aspects of managing portal hypertension, and I gave my take-home message on those trials. One of them was a trial looking at patients with acute variceal bleeding with high risk of rebleeding, and this idea of doing preemptive TIPS. And it was a positive study, but remember that it was the study was confined to patients who had CPT scores of 10 to 13, so it's a pretty narrow selection criteria. So it may go forward, may be incorporated into guidelines, but it's going to be very few patients, I think, to whom it's applicable. Anticoagulation remains important consideration because of this idea that the microenvironment in the liver may be prone to getting thrombosis, and that could accelerate cirrhosis and its complications. This is one in which we're still waiting new trials, but there is a direct-acting anticoagulant whose readout on the trial is expected this year. At this time, it's not ready for prime time, but I think is forthcoming. And then statins. Again, we come back to statins, shown to have an association with lower incidence of decompensation and mortality. These are in epidemiological studies largely. Personally, I don't think there's not quite enough data, but they're safe. They're broadly used, and so I would say that in many cases, we're likely to see these incorporated into guidelines. And he left with, I think, which is the most provocative, really, study that's come out, and whether this is going to come into guidelines, I think, is yet to be seen. This is the Pedestal study, in which they used a non-selective beta blocker as a way to really in individuals who had compensated cirrhosis but clinically significant portal hypertension. And as you saw from the results he presented, that the group that was randomized to getting propranolol or carvedilol, of course they were adjusted based on HVBG, they actually had a lower rate of getting decompensation. So this, I think, could be a game changer. And he predicted that a new recommendation might be anticipated this year related to this study. Ascites remains a big challenge, and Professor Rudler I think reminded us of just how challenging it can be, that it remains a complication for which when it occurs, it is associated with poor prognosis, and that concurrent with its development, you should be thinking liver transplant. And she defined non-refractory ascites as a sort of an entity that maybe has specific treatment, and in this regard gave us updated information on the albumin infusions and use of TIPS. Here's the Albumin Study, the so-called ANSWER study, in which patients who had non-refractory ascites were randomized to receiving albumin for 2 weeks, twice a week and then weekly, versus just receiving diuretics. And you can see that overall it reduces the number of individuals who needed large volume paracentesis. And so this suggests that this may be an answer for some of our patients with non-refractory ascites. And ongoing trials are also looking at this as a potential benefit in terms of mortality. She also spoke at length about TIPS, and in particular, how you have to be very careful about how you select your patient for TIPS. That if you want good outcomes, you have to be thinking about how to select the patient well. And she covered in great detail, and I think helpfully, for all of us in terms of looking at both liver function, absence of infection, the cardiac status as important elements in deciding who should be recommended to undergo a TIPS for refractory ascites. And again, emphasized repeatedly, and I think appropriately so, that these are the patients that we should always be concurrently considering transplant. She left us with the newest sort of kid on the block, which is the alpha pump. New studies, another study is just being started in the United States related to this use of this alternative. It's really one for patients who are not transplant candidates, I would say, and who are really otherwise refractory. It's interesting, and I think the caveats are there is the cost, the learning curve, and as yet probably the modest number of patients treated. Professor Durand reminded all of you of this very new, relatively new, but increasingly recognized acute on chronic liver failure entity. It requires the presence of cirrhosis. It's characterized by having organ system failure, and generally there's a clear precipitant. Infection probably being the most common, but others can be present. We characterize the number of organs failed, and each number of organs with each number that fails, or as the number goes up, the mortality increases as well. The most important message about acute on chronic liver failure is its high mortality, with overall 28-day mortality greater than 15%. And he highlighted this vicious circle of acute on chronic liver failure, where your patient sort of starts at acute decompensation, and one organ after another fails as they really go through this vicious cycle of continued complications. We would want to have a rescue therapy for sure. GCSF and MARS have been looked at, but really have not been shown to be helpful, and right now transplantation remains the only option. But I think he highlighted very well that there are probably patients in whom liver transplantation should not be offered, that it is futile, and really defining that cutoff is really an important aspect of this entity of acute and chronic liver failure. And then finally, the last speaker, I think, was really gave a masterful update on the advances in imagery for liver tumors. I came away with a few new tips that I'm going to take back to US. I thought it was very interesting to really think about how the liver imaging can really help us with prognosis. And I honestly had not always thought about having an MRI as my source for intrahepatic characterization of disease, so when I'm trying to stage a patient. So that was an important takeaway for me. There's lots of new questions regarding sort of the screening modalities and how to do it best, and especially how to do it cheaply. And I think it's super exciting to see what we have coming down the pike in terms of the quantitative imaging, and how we're going to use artificial intelligence to help inform us in terms of liver cancers as well as other focal lesions of the liver. And with that, I'll thank you.
Thank you very much.